area because those of us who are in the blood bank, we know that this warm autoimmune hemolytic anemia is more than just a diagnosis, but it's a daily challenge. And we are going to discuss today, and we shall have questions and comments at the tail end of the presentation. So at this point, allow me to once again welcome all of you who have found time to join. And also, I want to believe that you can hear me clearly, and we will start just in the next few minutes. So today we are privileged to be guided through this landscape by Francis Awino. And Francis will unpack the serological investigations that underpins accurate diagnosis, and will also shed light on the real-world blood bank challenges that come with managing these patients. So I'm sure this session will not only strengthen our technical understanding, but will also sharpen our clinical judgment in navigating these very demanding scenarios in transfusion medicine. So I'm sure that we are all ready for this session. And Francis is not new to us. Francis is working with us at the Nairobi Hospital, but also he's a medical lab officer who has a specialization in hematology and blood transfusion. So Francis, I believe you can hear me, and perhaps you can say hi, and then you can be free to proceed. Thank you.
Good evening, everyone. Could kindly confirm if I'm audible?
Yes, you are.
Okay, thank you. Thank you so much. Welcome to today's session. I'm Francis Awino. I'll be taking you through autoimmune hemolytic anemia, serological investigation, and blood bank challenges. This is going to be an interactive session. So at the Q&A question and answer session, I've got two panels that we'll look at. One for the auto control and one that mimic auto antibody reactivity in the lab. So that is an antibody panel. I know it's a new area for most of us who are practicing in Kenya, because most labs or most centers do not go to that extent, but it's something that can be incorporated in our system so that we are able to give the best to our clients at the end of the day. But for those people who are preparing for their American Society of Clinical Pathologists examination, ACPI, to be a very critical area for them, because that is one area that is highly tested in transfusion. So, and I'm very sure you cannot sit for any CPI exam without missing a panel in it. So a panel is one of the most common questions, and it holds a lot of marks. So for those of us who are pursuing that area or that particular licensing criteria, also has something to take home. So before we move into the warm autoimmune hemolytic anemia, we'll start by talking about immune hemolytic anemia. From the word immune, it means that there is production of antibodies. So in this case, we'll be talking about autoantibodies. Those are antibodies that are able to recognize self-antigen, and then they attack, and in the process, they will result into lysis or hemolysis. That would in long run result into excess destruction of red blood cells, reducing the lifespan of these RBCs and culminating into anemia. That anemia can be severe or not. So in introduction, we talk about the immune hemolytic anemia. So immune hemolytic anemia, what happens is that the red blood cells are destroyed prematurely by immune process mediated by antibody or complement. So it could be either antibodies or complement. So complement, which means the antigen complex that is formed, the antibodies, the autoantibodies targeting the red cell antigen, in the body will form the complex. And then that antigen-antibody complex will be able to activate the complement system. And once the complement system is activated, the end result is a formation of a membrane attack complex or MAC that's able to create pus and result into hemolysis of red blood cells. And this can be presence and severity of anemia will depend on severity of the hemolysis, to what extent is the hemolysis happening, or the ability of the bone marrow to compensate for red blood cell loss. And we are even going to see the picture that you will be looking at in peripheral blood filling in cases of autoimmune hemolytic anemias. Because remember, in cases of that where there's reduced lifespan and excess destruction of the RBCs and anemia culminating, there will be the bone marrow will be reset to compensatory mechanisms. That is, the bone marrow will be made to produce more red cells, and so therefore you are likely to find things like reticulocytes in circulation. And the PBF, you are likely to find young cells of RBCs, that is polychromasia, and you are also likely to find you're also likely to find nucleated RBCs, and we'll discuss more around that. And as well as you'll also be able to find spherocytes. That is an indication that there's an hemolysis going on. So immune hemolytic anemia, the one is the initial confirmation of immune mechanism. That is demonstration of attachment of antibody or complement to RBCs of the patient. And this can be done in the lab by doing the direct antibody testing. That is the data, or DCT, direct film testing. If it is positive, then it means there is an evidence that there is a formation of antibody-antigen complex. Those red cells are coated in vivo inside the patient. So therefore, DCT is one of the tests that we use to investigate autoimmune hemolytic anemias. So for diagnosis, there will be decreased HB as well as HCT. And in most cases, as we have said, because the bone marrow will be set to compensate for the less hemoglobin in circulation. So therefore, you are likely to find reticulocytes. There will be increased reticulocytes count and conjugated bilirubin due to the hemolysis or breakdowns of the hemoglobin, and then also decreased aptoglobin. That is because the aptoglobin is the protein that binds the free hemoglobin system. And when red cells are destroyed, there is release of more of hemoglobin. And those hemoglobin that has been released will be bounded by aptoglobin. So autoimmune hemolytic anemias. One, the shortened RBC survival, as we have discussed. The RBC lifespan is about 120 days. So in case of this disorder, this will be shortened to less than that. And this can be caused by production of autoantibodies against RBC's antigen. And antibody-induced reaction include one, sensitization, agglutination, and hemolysis. So in classification, we can have warm antibody, autoimmune hemolytic anemia, and that is what we'll be discussing today. And in this warm autoimmune hemolytic anemia, what happens is that the antibodies involved is of IgG. They are warm antibodies and they react at 37, while another classification type we are likely to find is called antibody autoimmune hemolytic anemia, where this is mostly responsible for cold agglutinin disease. And this is caused by IgM, so it could be anti-M or anti-P or anti-I. So those are IgM, or it could even be ABO antibodies. And then we have got a mixed type scenario where you are having both warm reacting antibodies as well as cold reacting autoantibodies. So in terms of classification, we are just going to look at some of the things. It can be either primary or idiopathic. That is where the cause is not known. But in most cases, it will be secondary, either to autoimmune disorders, such as these scenarios we're likely to find in patients with autoimmune disorders. So what are some of the autoimmune disorders we are talking about here? This could be systemic lupus erythematosus, it could be rheumatoid arthritis, and others. Also patients with chronic lymphocytic leukemia and other patients having immunoproliferative disorders, viral infection, neoplastic disorders, and also chronic inflammatory disease. So it can be secondary due to those diseases that we've mentioned. And cold reacting antibodies, the ones that is responsible for cold autoimmune hemolytic antibodies, can also be primary or secondary. So it can be secondary to Epstein-Barr virus, Mycoplasma pneumoniae, lymphoproliferative disorders, PCH, idioplastic, and secondaries also to viral syndromes and in some extent syphilis. In the mixed type, so in mixed type, as we have said, you'll be having both IgG and IgM responsible for hemolysis of these particular red cells. So here you are having a mixed scenarios of both warm and cold antibodies in the system. And sometimes the data might be negative, but in most of the cases that the direct antibody testing, the direct antiglobulin testing will be positive. Can also be drug induced, that is drug dependent or independent. And of course, apart from the autoimmune antibodies, they can also be alloimmune antibodies, where this can be acquired through, can be responsible for hemolytic transfusion reactions and also hemolytic disease of the fetus. So in terms of characteristics of the reacting antibodies, we have two antibodies, that is warm reacting antibodies and cold reacting antibodies. So for the warm reacting antibodies, as we have said, they are IgG, rarely IgM is involved, and IgA is rarely involved. Those two are rarely involved. Mostly is IgG that is responsible for the warm reacting antibodies for the warm autoimmune hemolytic anemias. And for the class of antibodies on the other hand is IgM, but IgG can also be seen in cases of PCH, paroxysmal cold hemoglobinuria, and also the optimal reactivity, the warm reacting antibody, these ones react best at 37 degrees Celsius, while the cold reacting will react at a lower temperatures, less than 30. That is room temperature most of the time. And mechanism of hemolysis for the warm reacting antibodies is extravascular, which means mostly happens at the reticuloendothelial system or spleen, while in cold reacting antibodies, the mechanism is majorly by intravascular and it is mediated by the complement mediated lysis. Remember, IgM is the best complement, it's best fixed complement, so it will activate complements better compared to the IgG. And we'll discuss that in detail. So in here, you can have attachment of the membrane-bound IgG, and in some cases, we'll have the complements which have been activated. So the C3b will be able to bind directly to the macrophages receptors, and then there will be phagocytosis of these particular cells that are coated with the autoantibodies. So specificity is usually broad specificity, and it is mostly anti-resistance antibodies. So these antibodies are mostly directed to the high prevalence antigen, and high prevalence antigens here include the RESA system and even the KEL system. For the cold reacting antibodies could be extravascular, that is attachment of the membrane-bound C3b to macrophage receptor. So also remember they mostly is by complement mediated lysis, and during that complement activation, most of the C3 will bind next. The C3b is a larger fragment, if you know about the complement fixation. So therefore, they'll bind next to the target cell. And so by binding next to the target cell, again, this can be binded directly by the macrophages and phagocytosed of these particular cells. It mostly, in terms of specificity, is auto-anti-high and occasionally auto-big high, and then occasionally auto-anti, the small I, and PCH mostly auto-anti-P. So in terms of sites, as we have said, the sites can be either extravascular or intravascular. So that will be depend on the class of the antibodies. And we have said for intravascular is IgM specifically, and most of the time. And then extravascular, we are talking about IgG class of antibodies. Then ability to fully activate the complement cascade. And IgM, they are able to activate complement, as well as even IgG, they are able to activate complements. And even if you go in details, we can talk about even the subclass of IgG, the IgG3, that one activates complements better compared to 1, and followed by 1, and then finally 2. And for IgG to activate complements, they need to be in close proximity, and you need at least two molecules of IgG to be close to each other in order to activate complements. And remember, for complement activation, it starts by the C1q binding to the Fc gamma receptors on these antibodies. So the IgG, the IgG have got a single Fc gamma receptor in their surface, while the IgM has around 3. They are pentamers, so you have like 10 of them. So that one has like at least 3 Fc gamma receptors in the surface. And so therefore, that's why it easily binds the C1q of the complement system and then activate the classical pathway of the complement system. So intravascular hemolysis mostly is complement mediated. And for the complement cascade, as we have said, it will start by the C1q binding to the Fc gamma receptors. And once that one is done, to be able to activate the C1r. And C1r is what will cleave the C1s. And C1s has got two substrates, which is C4 and C2. So C4 is the one that is cleaved first to give us the C4a and C4b. And complement 4a is an aphylotoxin, so it will be able to diffuse away and recruit inflammatory cells, including macrophages, including mast cells, and even B cell to the site of infections, so that you can have more inflammatory cells such as neutrophils coming on the site of infection. But we have C4b. C4b is a large fragment, and what it does, it will bind next to the target where the antigen antibody complex is. And once the C4b binds, then it will cleave the C2, the complement system 2. So that complement 2 has got two fragments, the C2a and C2b. So the C2a is the one that is larger, it's the opposite one, and then C2b is smaller, able to diffuse and recruit more other inflammatory cells. But now we have a combination of C4b and C2a, which will act as C3 converters, converting our C3 into C3a and C3b. And C3b in complement activation is normally kind of amplified, because just one complement activation will be able to give us around 200 molecules of C3b, and most of this will diffuse, and some of it will bound next to the immune site. Why am I saying this? Because C3b will be very key in immune clearance. They'll be able to diffuse into the system and bind more of the immune complexes that are forming in case of autoimmune disorders, and takes them to the spleen or to the reticuloendothelial system, which is rich in macrophages. And then macrophages will be able to phagocytose and will be able to remove these particular immune complexes that are formed in the system. Again, that C3b will also bind next to its target sites. And the C4a, C4b, C2a, and C3b will now give us the C5 convertase. And that C5 convertase is what will convert the C5 into C5a and C5b. And another thing about C5a is also the most specific anaphylatoxin. Somebody is unmuted. The most specific anaphylatoxin, it's the most potent one in recruiting the inflammatory cells compared to C4a or C3a, compared to the two. But once that one C5 is activated, then the C5b will be able to activate the rest of the complement from 6 to 9, giving us the membrane attack complex, that is MAC that you are seeing here, and the end result is the lysis, and that's what mostly happened in intravascular hemolysis. And you've seen, because this is happening inside the vessels, and I've also explained how the same immune complexes that are formed in this particular picture can find themselves into the reticuloendothelial system by the help of the C3b. For C3b will be able to bind them. And remember, macrophages I've got the complement 1 receptors that is binding the C3b and helping in clearing of the same through phagocytosis. So that picture actually summarizes what we have discussed. So you've seen a macrophage, and this macrophages is having the Fc gamma receptors that will be able to bind the complement system, and we have said that complement system, it is the C1q that will be binding to the Fc receptors. And the other hand, also the C3b will be able to bind. And another thing about this hemolytic anemia is because it involves red cells, and erythrocytes have got complement receptor 1, receptor 3, I think, on their surface, which is which will be able to bind to the C3b, and also enhancing these to be bounded to the macrophages for again for phagocytosis. And there is something known as zeta potential. It is the one that keeps the RBCs apart and prevent them from agglutinating. And so therefore, for these cells to agglutinate, then you have to break that zeta potential. Yes. So you have to break the zeta potential or lower the zeta potential. And that's why I explain why one IgG antibodies is not able to cause a visible agglutination. And if you are doing our DCT or ICT, then we will need AHG to form a bridge so that you are able to observe the agglutination. As you can see, it's about 25 nanometer in the length. And so the reason why IgM, which is pentamer, is about 35 nanometers. So therefore, with IgM, it is able to span the space between the zeta potential that is keeping the RBCs apart and give us a visible agglutination, unlike the smaller IgG, which is only spanning about 14 nanometers. So you might need more than one molecule of that. So factors which are affecting the rate of hemolysis in immune hemolytic anemias will include the class of immunoglobulin coating the erythrocytes. So that is one. For IgG subclass, the affinity of macrophages receptors and the rate of hemolysis is greatest for Ig3, as we have said. We had explained earlier that in subclass of IgG, it is 3 that is the best complement fixer, and then you move to 1 and finally 2. Then the quantity of the immunoglobulin molecule per erythrocyte. So the immunoglobulin coats a cell with a high density or in large numbers. And then another factor would be ability of the immunoglobulin. Somebody's, Fred, kindly unmute the person who is muted. So ability of the immunoglobulin to activate the complements, and here are having got IgM and IgG, which is activate complement. So for the IgG, the ability to activate complement is in that order as we discussed: 3 greater than 1, and then 1 greater than 2. Then the activity level of the macrophage, that is suppression of the Fc gamma receptors, decrease the rate of hemolysis, because it means if they are suppressed, then they'll not be able to bind more of the immune complexes to cause phagocytosis and finally hemolysis. Then complement component on the membrane, macrophages have receptors for the C3b, but not effective receptors for C3b. So having given you the overview of what immune hemolytic anemia is, I'll move straight to the autoimmune hemolytic anemia so that we are able to understand it. So immune tolerance normally prevents formation of autoantibodies, where autoimmune disease can occur because of one genetic, could be as a result of genetic predisposition, exposure to infectious agents. I think somebody. Exposure to infectious agents, that is molecular mimicry, then defects in regulation of immune tolerance. So in categories, you could have warm versus cold autoantibodies, and that could be as a result of primary or secondary, as we discussed. For the warm autoimmune hemolytic anemia, it will account for about 70% of cases of autoimmune hemolytic anemias, and then optimal reactivity, because they are warm antibodies, they react at 37 degrees Celsius. They are mostly IgG and rarely IgM and IgA. Most antibodies will react with rhesus protein complex, as we have said, in terms of specificity. Ali Karachi, kindly mute. Most antibodies will react with the rhesus protein complex. We'd say that the most directed to the high prevalence antigen, that is the rhesus and the KEL system. And this one do not, some will, and so therefore they do not react with rhesus null or rhesus deleted cells. Occasionally have single specificity within rhesus systems, such as anti-E. And it will account for 70%. Hello, Fred, are you able to hear me?
Yes, we can hear you very well.
Would you kindly Ali Karachi? So this one will account for 70% of cases of autoimmune hemolytic anemias, and most hemolysis is extravascular via the splenic macrophages. And what happens here is that the macrophage will be able to remove the bound antibodies on the surface of these erythrocytes. And so therefore, that's how we end up having spherocytes being formed into circulation. So the idiopathic one, that is the one that is primary, will account for about 60% of cases of warm autoimmune hemolytic anemias, and acute idiopathic warm autoimmune hemolytic anemias, that is severe anemia, developing over 2 to 3 days, and hemolysis is limited. So in these cases, hemolysis will be self-limited. The anemia can be severe. It can develop for over 2 to 3 days or several weeks, and that could even go to several years later. So secondary, mostly associated with lymphoproliferative disorders such as CLL or Hodgkin lymphoma diseases, neoplastic diseases, autoimmune disorders such as SLE, rheumatoid arthritis, Crohn's disease, and so on, while certain viral and bacterial infections, as well as vaccine, can also elicit the same.
Francis, you can unmute yourself, Francis.
Okay. Okay. Am I clear now?
Yes, proceed.
Thank you. So in terms of incidence, it's common in the older age, that is after the age of 40. The common presentation that you'll be able to see in these cases is anemia. For the secondary autoimmune hemolytic anemias, the signs and symptoms will be primarily of the underlying disorder. So if it is CLL, you'll be seeing symptoms for CLL. And then this could be associated with mild to moderate splenomegaly. So splenomegaly is just due to the infiltration of the immune complexes. Remember, most of these immune complexes, they are taken to the spleen so that they are removed or cleared in the body. So therefore, that's why you have this patient presenting with splenomegaly. About 50% of the patients will have that. And also hepatomegaly can be observed in a third of the patients. So for the lab findings, for immune-mediated hemolysis, one will say the test that we'll use to detect this is DCT or direct antiglobulin testing, which will be positive, and you can also do elution of the same to identify the autoantibody in the serum. And also, when you are doing a peripheral blood film, presence of spherocytes will point to hemolytic anemias. So in peripheral blood films, you'll look at moderate to severe normocytic, normochromic anemia, reticulocytosis, polychromasia, nucleated red blood cells, spherocyte, as well as schistocyte. So those are the key findings that you're likely to get on peripheral smear. And that is an example of our peripheral smear. So if you look at this PBF that I've just projected above, where my cursor is, this type of cell, we call it nucleated RBCs. And that this is an indication that the bone marrow is compensating for the anemia. So this is a compensatory mechanism. And this is another nucleated RBCs. And if you look keenly, you see like this cell here, this one is a spherocyte, and there's another spherocyte here. So the ones that I'm pointing. So we had said, and you know how the spherocytes form. So the spherocytes is forming as a result of the antibody coating being removed by the macrophages or at the reticular endothelial system. So what happens is that what the reticular endothelial system will do, or the macrophage will do, is to remove the antibody that is coating the membrane of the erythrocytes. And so therefore leaving you with a dense cell, a cell with a central pallor that is dense and small. And so that's what the spherocyte is. And these cells do not have longer lifespan. They are removed through the spleen. And so that's how the extravascular hemolysis happens. So again, that is another PBF. So in this PBF, we are having a nucleated RBC, which is this. And then also in this PBF, we are having a polychromasia, which is this one here. Polychromasia is an indication of reticulocytosis. So if you do a reticulocyte count, you are likely to find that it is high in this particular patient. And also if you do the stain, which stain are we using? The presyl blue stain or methylene blue, whichever vital stain you are using in your lab, you are likely to find it positive for reticulocytes. And then again, of course, spherocytes, and you'll be able to see a typical spherocytes like the one I'm pointing at. So those are the key findings in peripheral blood filling. So in bone marrow, you'll be able to see erythroid hyperplasia because, as we have said, the bone marrow is forced to release more of the, to increase the production of red cells to compensate for the anemia. And so that's why you are able to see erythroid hyperplasia. And you are also able to see the young cells coming into circulations like the reticulocytes. We talk about, the polychromasia, and of course the nucleated RBCs. So other lab tests, you are likely to see a positive direct antiglobulin testing. And remember, when investigating for a warm autoimmune hemolytic anemia, you're supposed to use AHG reagent that is polyspecific so that you are able to detect both anti-C3b or C3d together with the IgG. So it will be positive for polyspecific AHG and anti-HG that is monospecific. So in cases, if you look at the presentation on how it is, about 67% of cases are positive on polyspecific HG, and only about 20% will be positive for the monospecific HG, and about 13% for the monospecific anti-C3d or C3b HG. So you will investigate using the polyspecific one so that you are able to pick that. Differential diagnosis would be positive that autohemolysis test not corrected by glucose and non-homogeneous population of spherocytes. Common findings, as we have said, you will you're likely to find a positive direct antiglobulin testing in this scenario, and also normocytic normochromic anemia when we do your peripheral blood filling. There will be increased reticulocytes if you do the vital stain or you do the reticulocytes count. And then spherocytes and other erythrocyte abnormalities, as I've shown you in the PBF picture, you are able to identify what a spherocyte is and what is a nucleated RBCs. Then the presence of autoantibodies in the serum, increased serum bilirubin, of course, and in both total and unconjugated bilirubin. Why is it unconjugated? Because remember, this is pre-hepatic jaundice. It is just before the liver staging. So therefore, what is increased is in the indirect bilirubin and not direct. And then decreased serum aptoglobin, where they explain the function of aptoglobin is what binds the free hemoglobins. And so if there is hemolysis of red cells, then it means more of the hemoglobin are released into the circulation. And of course, elevated lactate dehydrogenase, that is also another marker that you can use to detect hemolysis in the system, because LDH, particularly serotype 3, I think so, is the red cells is one of the cells that have got high concentration of LDH. And so if therefore, if there's lysis, then it is still an indication of hemolysis in the system. Then positive antibody screen with all cells, including the autocontrol. So if you are doing the antibody screening, all the panel, all the antibody panel or the antigen panel that you'll be using for this particular test will be positive in case there is an auto antibodies and incompatible cross matches with all donors. So that's the major challenges you are likely to find. Remember, we said these particular auto antibodies, they are mostly directed towards the high prevalent antigens such as KEL and rhesus. So other laboratory findings, of course, there will be increased osmotic fragility due to high level of spherocytes and increased urine and fecal urobilinogen, hemoglobinemia or hemoglobinuria, and hemosidenuria. So in terms of treatment or therapy, it is self-limited hemolytic disorders. That is if it is not severe and the anemia is not evidence, because remember again, we said pre-hepatic jaundice is never that serious because the liver most of the time is able to handle the overload and conjugate. And this one do not require transfusion if it is not. And also the patients would be needing transfusion, and the challenges that we are likely to find at the blood bank level is difficult in finding compatible donors. So it is advisable that if you are having a patient with warm autoimmune hemolytic antibodies, you give them rare blood groups. So you transfuse them with rare blood group. So in our case, rare blood group maybe would serve as O rhesus negative when that is not the case. There is other blood group system, but we are not able to screen to that level. So maybe at our level, we might consider O rhesus negative. So in terms of treatment, they are monomassively given immunosuppressive drugs, at least to suppress the production of the autoantibodies. So this could be cytotoxic drugs. And also in case of severity and where there is splenomegaly, you could have splenectomy, removal of the spleen. And another drug that can be used is rituximab. So rituximab is an anti-CD20 drug. So CD20 is what is needed for activation of B cells. And so therefore, if you give these particular patients this drug, this drug is able to block the CD20. And so therefore, there will be no activation of the B cells will not be activated. And once they're not activated, they're not to be able to differentiate into plasma cells, giving us the autoantibodies. And another therapy that you can give is immunoglobulin, that is IV immunoglobulin, high dose intravenous of immunoglobulin, and also plasma exchange and plasma pheresis. So plasma exchange, you remove the plasma that is having at least you remove the patient plasma containing the regular antibodies and you give them the one that doesn't have. And having come to that, I was rushing so that we look at we have a discussion around this panel here. They'll take around 20 minutes at most to look at it. So this one requires maximum concentration. And I would urge every one of you to be very keen. First of all, I will start with the key or giving you the skeleton of this particular panel. So this is a 11 panel antibody ID. So if you are doing antibody identification, then you can use this particular panel. I doubt if there's any lab in Kenya who does this, but at least for those people who are preparing for LCPI, you will not be seeing something like this for the first time. So here we have got the column. So this first column here is giving you the phenotypes of the 11 donors. So I'll call them donors, the cells that we are using from number 1 to 11. So like in the first cell, the donor there is R1, R1. The second one, R1, R1. Now you have to jog your memory on the rhesus system. So in the rhesus system, if you see capital R with 1, then it means that the antibody that is there is capital D, capital C, and small e. Yes. So where there is R1, it means that the D antigen is present. Remember, in rhesus, it is an haplotype. So we have got three genes that are inherited together, or rather exist in one locus or allele, the three of them, and it is inherited like that. So you have either DCE or DCE like that, or or you can have DCE, and then you will get 50% from one parent and another 50% from another parent. So in this case, it means this patient, is the phenotype there is D, capital D, capital C, and small e, and it is in homozygous state, that is in double dosage. And that is the same for cell 2. And then for cell 3, it's just more or less the same thing, but what is there here, we are now not having the small e, so we are having the capital E. So instead, this will read D and then small c and the capital E. And then for this other patient here, if you look at the phenotype for the R0, this particular patient is having the R0, which means for the R0, the two small c, and you can even confirm with the reactions here. As you can see, like for this R0 here, this patient is having a positive reaction for both the small e and the small c. And then, of course, capital D. And then remember, the dominant gene is what will be expressed. So from one parent, the patient got, the donor got that. And then on the other patient, the other parent, the small r, is the small d. And then, of course, the small c and the small e. Then now, the rest of the cells from 5 to 6 is where the D antigen is missing. So these are rhesus D negative donors for panel, from panel 5 to panel 10. So this panel here, they're just having the small, they're just having the CE rhesus system, but not the D antigen. So like in 5, it is R,1, R small. So this patient is not having the D, of course, but the patient is having the big C. And also the patient will have, of course, there's also R not here, so the patient will also have the small c and the small e, and of course the capital C. And you can see that is what is presented in these positive reactions here. And then where you are seeing R,2, that's where now the capital E is present. And of course, because there is R naught, so the both small c and small e will be present for the rhesus system. And RR, they are all small. There is no big DCE. So that will be the case for cell 8, cell 9, and cell 10. And of course, cell 11 resembles cell 1, so we'll not discuss it. So after looking at that column, I'll take you to this first column here. So this first column where my pointer is, that is the rhesus system. So in the rhesus system, so normally they group them based on the blood group antigen. So like in the first area here where we are looking at antigen in the rhesus system, and now we are having the D, the capital D, capital C, small c, capital E, small c, small e, like that. And of course CW, and then in this column we'll be having the high prevalent antigens, the likes of less prevalent antigens, the likes of anti-vel, this one here. And also then you jump to the KEL system. So in the KEL system, you'll be having the capital K and the small k. Then you will also move to DAFI, where you're having FYA, FYB, and KID, JKB, JKA. And then of course P, these are IgM, Lutheran, and then MNS. MN will be IgM, the small s and the capital S, these two will be IgG, and finally Lewis. So what you need to understand, here we are having the other blood group system. So the first part, we are having the rhesus system, then we are having the KEL system, we are having the DAFI system, the KID system, the P system, the Lutheran system, MNS, and Lewis. Then you also need to understand the characteristics of these particular antibodies and how they react. Like for example, Lewis, these are IgM, so therefore they are called reacting antibodies, and they will react at immediate spin space. And then this MNS, we have got two groups. We have got the cold reacting antibodies for the MN, and the SS, those ones are warm reacting antibodies. And then now we have got Lutheran, then we have got P, and then we have got KID. So the KID again, I'm just looking at the major ones. The KID again are warm reacting antibodies, and DAF is warm reacting as well as K. So another important thing is the phase of reactions. So the phase of reaction here for the receptors, they're able to react both at 37 and at AHG phase. But for the KEL system, for the DAFI system, for the KID system, and again for the MNS system, these ones can only react at the AHG phase. And that's why I now explain why you are not supposed to omit AHG at all costs when you are doing your cross-match in the lab. Because you will miss, if you miss the AHG when you are doing your cross-match in the lab, then you are unlikely to capture anti-KEL, anti-DAFI, anti-KID, and anti-S. And I can tell you for sure, anti-KEL, anti-KID, and anti-DAFI, they're also responsible for delayed hemolytic transfusion reactions. So do not miss AHG at any given point when you are doing your cross-match in the lab. At least for research, you will be able to pick it at both at 37 and at AHG. Now you come to the last part of it, where the results is. So where the result is, in this panel, that's normally how these panels are presented. So if you see a panel that is having an IS here, that is immediate spin, and then they are having 37, and then they are having 80. That is tube method. That one resembles the tube method. So these things can be done manually in the lab by tube method. And then if you see a panel that is just having an immediate spin and AHG, that is polyethyl glycol, PEG. That is PEG that is being used most likely because PEG has got non-specific reaction under 37. So therefore, most of the time it omits 37. But if you see a panel like the one we are having, it is not labeled. Mostly this is presumed as gel testing or solid phase testing. So like in this case, this particular lab that was seeing this patient here, we will also go to the history, is likely to be using automated platforms like IRIS, or they could be using the gel technique methods. Having given you the anatomy of this chart that we presented here, what do you normally do when you are doing antibody identification? So the first thing, you will start by the history of the patient. That one is very key because that is what will guide you. And then once you look at the history of the patient, look at the auto control, if it is positive or negative. And it should be negative in most of the cases. If it is positive, then that one indicates a presence of autoantibody. So if autoantibody is present, what we've discussed in warm autoimmune hemolytic anemias, if the autoantibody is present, all these cells will be reactive. So you'll be seeing a pan-reactive, where all the cells are reacting because of the autoantibodies. So for this, our case, it is unlikely to be autoantibodies because we have got several cells that are negative. Having looked at that, you'll also look at the pattern of reaction. So the pattern of reaction will be able to tell you, like now this is AHG phase. So of course, you know, the antibody that is causing this particular reaction is a warm antibody or IgG antibody. So if the pattern of the reaction will be able to tell you if it is uniform, for example, all the reactions you are seeing is 3+, 3+, 3+, 3+ in that panel, then that is a single allo or autoantibodies. But where there is variation, like in this case, you are seeing 1+, you are seeing 3+, it could be a single IgG antibody, either allo or auto, but that antibody is expressing dosage effect. So again, we need to understand things like dosage. What that dosage means in immunohematology. Dosage simply means that if this antibody is present in their homozygous state, like for example in cell 1, where we are having R1, then they will give a stronger reaction of 4-4. But where it is present in heterozygous state, like for example in cell 4, where we are having R0 small r, then the reaction tends to be weak. But where it is in double dosage, it gives a stronger reaction. When it is in single dosage, like in heterozygous state, it gives a weaker reaction. So again, that's another thing that you need to understand before we start now crossing the panel. and trying to see which antibody is responsible for this particular reaction. So having talked about that, now let's look at the history, because now we are getting to the real work now. The other one was just the anatomy. We are just giving you the basic that will enable you to work with this particular panel. If at all you want to practice in those countries, you will meet these things. Or maybe if you are preparing for your ACPI, then I can tell you for sure, you can never miss a question on this. So let's look at our patient for this case, in this particular case study. So in this case study, so this is a 47-year-old female with a history of breast cancer. So the patient is having breast cancer. And this patient is in remission for 10 years after autologous stem cell. So that's another thing, because this patient have undergone stem cell transplant. And so they're also capable of producing auto antibodies, or antibodies that could be able to target their own cells, or even developing things like graft versus host disease, where that particular, but remember it is autologous stem cell. So for this case, there is no really risk for the graft versus host. So let's stop that one there. So what next? The patient was hospitalized for 2 weeks with pneumonia. Okay, that's what brought the patient in the hospital. So in the history, they realized these patients had no previous antibody history, which means they did not this particular patient had not developed or have not been sensitized before. However, there is a very important history here, and this is what carried the day in this particular panel. There are 47 RBC transfusions, and most recent was in 8 days. And that one even explain, if you look at our auto control down here, where the pointer is, I hope I'm not losing anyone. The 1+ there is an MF in bracket. So that MF is a mixed field reaction. And that mixed field reaction could simply be caused due to the transfusion, because the transfused cells are still in the system of the patient. These are patients who have gone massive transfusion, about 47 of them, and it is in the recent day, 8 days, and that's why you could be seeing a mixed field agglutination. Let's come to the to the blood grouping. So if they did a blood grouping, the patient, according to the forward grouping, our patient is A, and of course reverse is agreeing, because we are having a very strong reaction with the B cells, confirming this patient to be blood group A positive, because we are also having anti-D. They went ahead and also did DCT, or direct antiglobulin testing, and with the polyspecific one, they were getting a weak reaction of 1+ and a mixed field agglutination. And then we are also having an IgG, a monospecific AHG reagent that is specific to AHG. And sorry, the arrow has blocked, but this is 2+. This was giving them a 2+, a bit stronger reaction, moderate, let's say moderate reaction, but also with a mixed field, and then C3D with the 1+. C3D just rule out the presence of IgM. So most likely in this case, we are dealing with IgG alloantibodies towards the recently transfused what? Towards the recently transfused cells. And so that's why you are seeing a mixed field agglutination, where that antibody, the halo antibody that this patient has acquired, is able to give agglutination with the recently transfused cells, while the patient cells are also there. And so the patient cells remains free. And so that's why in mixed field, we simply mean that some cells are not agglutinating, while some cells, there is also a picture of agglutination. And so therefore, we are having a mixed field. So when they did the indirect antiglobulin testing, they didn't find a reaction with cell 1 and cell 3, but it was positive with cell 3. And so therefore, having a positive DAT and a positive ICT, they decided to do an antibody identification. And that's what we want to do together. But remember, this is not a case of autoantibody, as we have said, because if it was an autoantibodies, then you expect a pan reaction, a pan positive reaction. All the testing cells are likely to be positive on the result. Now look at the column of the results. But now in this picture, of course, we are yet to get to the real work and know which antibody is present in this case. But in the picture alone, we have known that the antibody could be a single antibody, or there could be multiple antibodies. But if it is a single antibody, then that single antibody is expressing a dosage effect. Where in cells where, or rather in panel where in panel of cells where it is in heterozygous state, it's giving a 1+. But where it is in homozygous state, it is giving a 3+. So another thing that you need to know whenever you come across this particular question in your ACPI, now that we don't do it in our real lab, you need to know that 1, you have checked the history. 2, you've looked at the pattern of reactions which we've done. No, very important, you've looked at the autocontrol. It should be negative. So therefore, you rule out the autoantibodies. For this case, the cells which are, as much as it is a very weak reaction, it is a mixed field. And you've also looked at the pattern that you have given there. So another thing, now we need to move to the crossing. So in the crossing, personally, I find it easier to work with the negative cells first. Remember the antibodies you are looking. If it is absent in those particular cells, it will give a negative reaction. So I will start with the negative cells, all of them, the ones that are lighted in yellow first, to look for what is not there. Then once I found what is not there, I go to what is there. Because now you want to see this antibody that have identified, is it explaining the positive reactions? And according to the AAB standards, you need at least 2 positive. It should explain, perfectly explain 2 positive reactions and at least 2 negative reactions. But preferably, they prefer you use at least 3 positive reactions. Your antibody should explain at least perfectly, explain at least 3 positive reactions and at least 3 negative reactions. So how do we cross? Like, for example, I'm having my negative cell as cell 1, cell 3, cell 4, cell 6, and cell 8. I wish I was able to merge them. Now that I'm not able to merge them, I just cross anywhere you see a reaction, you cross, because we are looking for antibody that is negative in all the negative cells, the ones that are giving 0 reaction. So like here, we're having Lewis B. It is already having a positive reaction here. I cross it. Then I move to Lewis A. You will cross it because it is having a reaction at cell 6. And then you move to, this is small s, positive already, cross it. Then big S, you will cross it just like that. Within few minutes, we will be done. But this one require concentration. And maybe you just have a pen and a paper around you so that if I say this is the likely antibody, you write it down, and then we look at the positive reaction and how it comes and how it explains the positive. I mean, we look at the antibody and then we look at how that particular antibody explains the positive reaction we are seeing. So if we move to N, so I'll just go antibody by antibody. If I move to N, I can see N already there's a reaction on several cells, so I will not take N. If you move to M, of course, but it is reacting with cell 8. We'll cross it for that case, but you can just write M hapo kando na uweke star. You can just put a star beside M. We might just look at it later as a so you can just write M later. We'll use it to explain something. And then, so for this, we have got Lutheran. So for this, we have got Lutheran. So for Lutheran, those are antibodies that are highly prevalent antibodies. It means that these antibodies, you are likely to find them in almost every cell. So in immunohematology, you say, don't get worried about them because you are likely to find them in almost every other cell. So that one we jump. We'll also jump this other one, Lutheran A. That is the less prevalent one. You are unlikely to find it in almost every cell. Then we move to the P. There is a reaction, so we'll cross. We'll move to KID. KID is IgG. So for KID, yes. As you can see, there is no reaction with cell 1. For JKB, there is no reaction with cell 3. There is no reaction with cell 4. You move to cell 6, no reaction. Cell 8, no reaction. So at least for JKB, it is not reacting with any. So that is one antibody that we will pick, and then we'll discuss in detail. Then if I move to JKA, of course, we'll cross already having a reaction with cell 1. Then we move to Duffy system. FYB is having a reaction with cell 3, so cross. Fred, am I audible? I hope you people are able to hear me, but please confirm if you are not able to hear me. I don't want to lose any of you at this juncture. So we were crossing, and what we had picked as very significant for this particular antibody panel was JKB so far, but we are at Duffy, and Duffy there's a reaction with cell 1, so we'll knock out Duffy. So we'll move straight to the KEL system. For the KELs, these other ones are more frequent, so we'll just concentrate on the bigger K and the small k. So for the small k, as you can see, there's a reaction, so that one will remove. But for this bigger K, yeah, so again, we can pick anti-KEL for this case, anti-KEL for this capital K, because there is no reaction with cell 1, cell 3, and cell 4. Those are negative cells. And then also no reaction with cell 6 and cell 8. Then we'll leave and we'll jump these less frequent antibodies like the VCWF and straight to the RESA system. So this should be the small e, we'll cross it. And then the small c, again, small c is reacting with 3 and 4, so we cross it. And then the big C is reacting with this, we cross it. So out of this, we have, out of this reaction, we have identified 2. So we have identified anti-KEL, this one here, and we have identified KID, JKB. So we look at those 2. So these 2, what you want to see if they are explaining, remember we said you first look at what is not there, because the antibody that we are looking for, if you react these particular antibodies with the cells that is containing the missing antigen, there will be no reaction. And that is what is happening in this particular cells. But again, if we expose it to where with the cells that are having this particular antigen, like for example, the cells which will be positive for JKB and big K, those we expect are positive reactions. So let's start with JKB. In the second cell where my cursor is, it is having a positive reaction of 1+. So another thing you are supposed to note here is that this JKB, the KID antibody, it is in heterozygous. So it is in single dose. And that's why you are seeing a weaker reaction. So it is explaining that reaction because that is a dosage effect. And again, because we isolated K, there is no reaction with K. And so therefore, that one perfectly explains that particular reaction. So again, let's move to cell 5. So in cell 5, you are seeing it is having a very strong reaction with what? With the cell 5. And cell 5, it is having a reaction with the 3+, but remember JKA is negative, and so therefore it is in homozygous state or single dose, expressing a strong positive, a strong agglutination, or rather a strong positive reaction. So therefore, that is another dosage effect. Perfect. So this one already met the 2 criteria. At least it has explained the 2 positive, and of course, all the negatives were agreeing. So we'll move to another, just a minute. In that cell 5, we'll also look at the K. K is missing again in that cell. So we'll just move to the next cell, that is cell 7. So in cell 7, we are having JKB again reacting, again in homozygous state, and is our anti-K there. Anti-K is also there. So remember, we are looking at 2 antibodies which are present in this case, anti-big K and anti-JKB, and so therefore we expect a strong reaction of 3+. Another thing, you'll move to cell 9. So in cell 9 again, we'll be looking at the reactions there, and we can see it is 1+, and it is because it is in single dose, JKA is present. If I run through, there is no anti-K. So therefore, that is reaction again is explained. If we move to cell 10, cell 10, for example, just look at where the cursor is. We are having again anti-KID, that is JKB, in homozygous state, and it is giving us a weak reaction of 1+. Let's just look across if we can find the big K. Is it there? So the big K is there. So this big K, most likely it is reacting weakly. And then again, we'll look at these cells. So another thing, look at, very interesting. Okay, so finally we are at cell 11. So in this panel, you can see the kid is perfectly explaining all the positive reactions, and it is indicating the dosage effect. And so therefore, this patient is having anti-JKB in their system. However, the anti-KEL that we isolated, let me just see what happens. Yeah, so this is explaining. The anti-KEL that we isolated is also reacting very weakly, and it is there in cell 10, it is there in cell 11, cell 10 and cell 11, as well as cell 7. So it is explaining 3 of the positive reactions, and in the negative reactions, it is not there. So we have isolated at least 2 antibodies for this patient, but we are having anti-JKB and anti-JKB and anti-KEL. So another investigation that you can do further to, after looking at this panel and coming up with your antibodies as JKB and KEL, you can now enhance or pre-treat these particular cells with enzymes. Now, what do you expect in enzyme reactions? So for the kid, you expect the reaction to be enhanced, like where you are seeing 1+. After treatment with enzyme, you expect the reaction to go higher by 4, to even give you a 4+. But for KEL, they will remain unaffected. So this, in conclusion, now we have identified, of course, there was allo antibodies in the system of this particular patient. They develop allo antibodies through this particular recent transfusion that they received. And that's allo antibodies, according to our panel here, it is anti-JKB, anti-KID, which is an IgG, and that's why it is giving us this. And that's why you are able to see a mixed field agglutination, because it means the donor cells which are positive, the donor cells which are coming with the JKB positive, or the ones which are positive for kids, are being agglutinated to give us a visible agglutination. And so, therefore, this is not a auto antibody scenario, but this is a scenario of allo antibodies, and in that case, it is IgG, and we identify anti-KEL, for example. And then in the last one, what we are looking at here is the real, it's not really clear, but this is now the real scenario where you are dealing with the autoantibodies. For this case, you don't even waste your time crossing anything, because this one is confirming presence of what? Auto antibodies. As you can see, the auto control is positive, and so therefore you will go ahead by doing your DAT is positive, and so therefore you go ahead by doing an elution, so that you are able to identify that the specificity for that particular auto antibodies. Thank you all. That's mark our presentation for today. Back to you, Fred. I know it was quite complicated, but I'm hoping we've learned something out of it. Thank you all.
Francis.
Yes, Fred. Are you still there?
Yeah, we are here.
Did I got lost? Maybe nimekuwa nikijiongelesha all along.
No, no,
Are you
no,
able
no.
to
We
get
are
me to
we are
start?
mentioning it. It's a very comprehensive presentation.
Few questions.
Did I hear you, Francis? What have you said?
I was saying we can look at a few questions if they are there.
Oh yeah, sure, sure. Yeah, there are a couple of questions. There are a couple of questions. So I think we can start with this one from Benson Lusenaka from Webuye. He's asking, is it possible to prevent autoimmune disorder?
Okay. It's really difficult in saying that we can completely avoid autoimmune disorders. But what I know, because autoimmune disorders, one, it comes with uh, the status of the immune system of the body. So if you're having a strong immune system, chances are very minimal that our patients will develop autoimmune antibodies. So yes, it will be possible for those ones who are having a strong immune system, but that will not be the case for the immunocompromised patients. So we'll look at case by case. For the immunocompromised patients suffering from chronic inflammatory diseases like cancer, patients suffering from autoimmune disorders such as SLE, it might not be possible. They are at risk of developing autoantibodies, and so therefore, what their doctors can do is to put them on some of the immunosuppressive drugs, at least some of the immunosuppressive drugs to prevent them, or other prophylaxis models that are available if there's any. Yeah. Then the next one.
Thank you, thank you. I think there's another one from Joel Anunga. He's asking, what is panagglutination and how do you differentiate autoantibodies from alloantibodies?
So panagglutination, as we had alluded in the presentation, that is where all the cells are reacting. Like we said, in case of autoantibodies, you'll find that this autoantibodies is able to cause agglutination with all the reacting cells. Huh? Or like in this, the one that we are projecting is having around 11 cells. So if it was a real case of, let me just move to the next slide so that we see the panagglutination. So for the panagglutination is something that is resembled. So for the panagglutination, okay, you are able to see now. So for the panagglutination is something that resembles this. You can see there is a reaction in all of them with 3+, but at least one thing that you can pick out of this reaction is that this is an autoantibodies, but this autoantibodies of a single specificity. So it could be just be directed towards rhesus antigen or even tail antigen. Yeah, because you can see the reaction is similar, all of them is 3+. So this is a perfect example of panagglutination. So the other one was how to do what? The question was having two parts. The next part was?
The next part was, he was asking whether, how we can differentiate autoantibodies from alloantibodies.
Very good. So autoantibodies from antibodies. So autoantibodies, we say these are cells that are directed against the patient's own cells. And that's why it's very important. I don't know, we really need to improve our transfusion system in Kenya. We need to move away from just doing cross-match with SRT and whatever. So because sometimes the reaction that the cross-match challenges that you're finding or the reaction that you are seeing is due to auto antibodies. So, and we are not going to take these auto antibodies, but just with the conventional normal cross-match. So it is also good always to incubate the patient own cells with their own serum at 37. So if you do that at 37, you'll be able to pick the warm auto antibodies. And if you incubate the patient's red cells and their red cells with their own serum, you'll be able to pick cold auto antibodies antibodies, because you incubate that at either room temperature, but preferably at 4 degrees Celsius. So they're called reacting antibodies. So that is now the auto antibodies. For the allo antibodies, this is it is a foreign material to the recipient, which means the recipient is, like now in this case, the antibody, the anti-kid that we have identified in this particular panel is directed towards the donor. Are you getting that? So it is the antibodies of the recipient system. They produce antibodies towards the donor, or yes, towards the donor. So that is now the allo antibodies. Yes, it is towards the foreign cells. Yeah, the ones that are coming. So, and you can see again, if you are transfusing this patient in Kenya, do you think you would have identified this anti-kid? In some hospitals, I know they only do the SRT and they don't even bother to go and do the AHG phase. Do you think they would have picked these transfusion reactions? They would have not. And the patient would have developed delayed transfusion reaction thereafter. And this would have even be treated for anything else. And as you can see, it was anti-kid. That is other blood group system. This one you can pick with AHG phase. So it is good to do the 4 phases, and whether you are doing manual. For automated, I know you have no option. You have to do it. It will automatically do the rest, all the phases together. Yeah. The next question.
I think the other bit is on, okay. How can we differentiate febrile reaction from hemolytic reaction, from Francis Mabili?
So for febrile reactions, we are not, they will not have the DCT will not be positive, but for this case where we are talking about auto or halo antibodies, the DCT will be positive. And febrile reactions are mostly due to, we call them what, allergic reactions. And this is mostly mediated by IgA. Yes, so that's how you will differentiate it. Because for febrile transfusion reactions, you will also notice fever, which will be very apparent. And like this, fever will be there, but not as in febrile reactions. And again, this is delayed. For this, like IgG subtype, the one we are discussing here, this one is a bit delayed. But the febrile is acute, so it will develop maybe 1 hour after transfusion, or even some few minutes after transfusion. So again, if you see you are having febrile reactions, you will transfuse together with analgesics. There's this drug they normally use, imenipotea kwa kichwa kidogo, but it resembles Panadol, lakini iko na jina ingine. You can use that analgesic and you give that. But for febrile reactions, in the lab, action will be to you give them wash red cells. You'll give them wash red cells. So when you wash your red cells with saline, you are able to remove the IgA or the antibodies that are causing that febrile reaction. Right, next question.
I think those were the only questions we had, unless there's someone who wants to either speak, but that is the only question we had. And we've also had a couple of compliments. Abel Nduki says very comprehensive presentation. We are still digesting. Jacqueline Otieno, excellent work. Fred Mose, nice presentation. Paina Washira, great comprehensive presentation. Georgian, nice presentation. Rofina Moreidi, excellent presentation. Ali Karachi, nice presentation. Elimelech Mbaka, good presentation. And many of you have been able to compliment. I may not be able to read all of them today, but I think those are some of the comments and a few concerns and questions that have been asked. So I think I think that is it. Maybe we can get back this to you, our speaker, for your closing remarks.
So maybe majority would forgive us for giving a complex area, especially in antibody identification, but I think it is also necessary because we are in an era that most people are registering for ACPI. And I know maybe out of this audience, several others are maybe due for the ACPI, or they have done, or maybe they have passed the ACPI, but that was a challenge. So at the end of the day, somebody needs to understand. So, and I also believe as our transfusion is advancing and growing in Kenya, we might at one point reach a point where we'll be doing antibody identification here, and we'll be doing this panel here in Kenya. will be doing these studies here. I know policymakers are in this platform, the likes of Dr. Rachel Gidiomi. Her paper is on this. I think she did something on other blood group system. I also know Dr. Mangare has extensively worked around this area. So we already have experts which are working around this particular area. So it is not really a new area, but the point at home, as much as we are not going to the specifics, as we are not reaching the end point of identification, treating them with enzymes. So now those other investigations to follow, the advanced specialized treatment that we do to rule out these particular antibodies, we need to follow our protocols to the latter. And at the end of this presentation, the take home is do not ignore your AHG in cross-match. So go with the 4 phases when you are doing your cross-match, you'll be able to detect these warm autoimmune hemolytic antibodies and even called autoimmune hemolytic antibodies, because you'll detect those ones at immediate spin. So it is very important that we look at that even as we are working in our labs, and by doing that, we'll be able to save these particular patients. So the small efforts that don't say that we are not screening for other blood group systems in Kenya. No, these other blood group systems, they don't exist in vacuum. They are most of them are warm antibodies. KL is IgG, they are warm reacting antibodies. Same to Daffy, same to KID, same to MNS. So it means if they are there or a patient has been sensitized towards that area, you'll be able. And which patient for in particular? Mostly sickle cell patients, the ones who have received multiple transfusion, they're likely to develop these allo antibodies. Which other patients? SLE patients, we have so many of them in our hospital. Arthritis is very common in old age, so they're likely to develop auto antibodies, and these patients will be admitted. We have got cancer patients, we have got kidney patients who have gone transplant. So we have got a huge group of population in our country here in Kenya who require these particular services that we are talking about. And of course, to sum it all, LMSK, you can see they have done a good job. We are not just talking about the routine things. We are also doing CMEs around other areas like antibody identification for expertise. So maybe in future, if someone wants us to do a similar presentation, or they feel like we need to do a repeat of the same, you can liaise with the LMSK secretariat so that we can have that one done. Otherwise, I want to wish every one of you a very good evening. Continue doing the good work in your hospital, but do not forget your cross-match. Do not forget your DCT. Do not forget your ICT. And do not forget to follow the due process by doing the 3 phases. Not all hospitals are privileged to have the automated platforms, but at least you can do something with the manual ones that you have. Thank you.
Thank you, Francis, for the wonderful remarks and also for a very comprehensive presentation. And I think we have enjoyed the presentation very much. It was quite insightful. So I'm sure that to all our participants, this has been a very timely discussion that will strengthen our commitment to accuracy and also to continuous learning. And we know and for sure that our decisions directly influence patient outcomes. So I'm sure that we have been able to pick something from this discussion, but it is not the end because we will continue discussing. These areas are not very commonly discussed amidst us, but I think this reminds us that the lab still plays a critical role, in unraveling these complex clinical decisions. So I think we have come to the end of today's session, and it was quite very interesting. I want to thank you for your attention, your dedication, and also your participation in this webinar. Otherwise, thank you. And on behalf of Lab Medicine Society of Kenya, I want to say thank you. You will receive your certificates just today, together with the ones that had not been sent. And for those of you who are pressed for the slides, I can see you writing your emails there. We may not really get back this chat after this presentation, but you can always reach out. We shall be glad, we shall be able to share with you. And I think so that we can grow together. Otherwise, thank you very much and enjoy the rest of the evening.